Hello and welcome to session 1. My name is Sujata Patel and I'm on the VCP Scientific Conference Organizing Committee. Today I am honored to introduce our panel for this session. We have Dr. Jordi Diaz-Manera, Professor of Neuromuscular Disorders at Newcastle University, Dr. Gerald Pfeffer, Assistant Professor of Clinical Neurosciences at the University of Calgary, and then Dr. Virginia Kimonis, Professor at the Division of Genetics and Genomic Medicine, Department of Pediatrics at UC Irvine. And they will lead a discussion of clinical symptoms, diagnostic tools, and pathological features. Each speaker will speak for about 15 minutes, leaving ample time for Q&A at the end. So I welcome Drs. Diaz-Manera, Dr. Pfeffer, and Dr. Kimonis. So Virginia, you're on mute, so you'll just need to unmute yourself.
Oh, thank you. Thank you very much, Sujata and Nathan, for the kind invitation. And I'm really looking forward to this historic moment, the first scientific VCP conference, and I'm very much privileged to kick it off. So yeah, I'm going to talk about VCP disease, now called multisystem proteinopathy, a genetic disorder involving muscle, bone, central nervous system, and much more. Let me see if I can. Okay, so this is the outline of my talk. I'll talk about the discovery, natural history studies, some genotype-phenotype correlations that we did, preclinical models that we have generated, and translational studies that are completed, some completed, which have given proof of principle, and some that are ongoing, and some that are planned. So this is the first family from central Illinois. Unfortunately, most of the patients in the front row are deceased, but there are many more future generations that are now beginning to manifest. So this was that first family where linkage was done, and we were able to produce a log score of greater than 3 in just that one family. With the help of recombinations in other families, we were able to map it to a 3.1 centimorgan region containing 80 plus genes. And with the help of collaborators, we divvied up all these genes to sequence. And luckily, my lab was the one that found the VCP gene. As you see here, most of the mutations in this gene are clustered in this N-terminal ubiquitin binding domain. However, there are mutations spread across the other domains of the gene. What the gene does, it's ATPase associated with a multiple of cellular activities. It makes up 1% of all the protein in the body. It's a homohexamer, and it has these 2 catalytic domains, the D2 being the most active of the domains. And it does its job by interacting with numerous cofactors. As you see here, the most important is the NPL4 and UFD1. So VCP has pleiotropic functions, but the most important function is associated with degradation of proteins, which it does through the ERAD pathway, lysosomal autophagy, mitophagy, and other pathways. And it, of course, does many more roles. It has many more roles than just degradation. So 90% of patients have inclusion body myopathy. There is a mean age of onset of around 35 years, and biopsies of the muscle show variation in muscle fiber size, rim vacuoles, inclusion bodies of TDP, ubiquitin, P62, and other proteins. What you see on the left is a gentleman with winging of his scapulae because of limb-girdle muscular weakness. On the right is a muscle biopsy showing the arrow in A showing a rim vacuole, and then what you see is inclusions of all this other material that I mentioned, and on the bottom left the PED helical filaments in the nucleus of a muscle cell. So Paget disease is seen approximately 50%. It is quite common in some populations, but the incidence is decreasing. It is thought to be perhaps due to increased measles vaccination, and this indicates that there is a genotype-phenotype correlation there in terms of the etiology of this disease. It is a painful condition because the overactive osteoclasts, cause bone to be very active, hard, misshapen. It can fracture and also rarely be associated with malignancies. 30% have frontotemporal dementia. There's cortical atrophy in those regions. There's gliosis, vascularization, and then there's accumulation of this TDP-43 ubiquitin inclusions. Approximately 10% of patients with VCP will develop true blue ALS, and in some populations, 1 to 2% of familial ALS are because of VCP mutations. We already know that people with frontotemporal dementia have ALS as an association and vice versa. So it was not surprising that ALS is a phenotype of this condition. Parkinson is also a known phenotype. I have only seen this gentleman and his cousin who both came to UC Irvine. He had absolutely typical Parkinsonism, which responded to dopaminergics, and his scapular winging and muscle biopsy, which was done quite late in his disease course, showed rare-rimmed vacuoles. This was our study that we published some years ago, looking at the genotype-phenotype correlations in 187 patients. So not all of these patients did I see. This was, largely a lot of the patients were based on ascertainment from pedigrees. So limited information was available, but of the information that we had, it was very useful to see that 90% had myopathy, 43 Paget, 29% dementia, 8.5% ALS. Parkinson was approximately 4%. Looking at just the major phenotypes that I mentioned, it is so heterogeneous, and it is not surprising when you have one member of a family, the same family have only dementia, one member only have myopathy, one member only have Paget, and then so many combinations thereof, that it's very difficult to diagnose these families, and this accounts for late diagnosis or wrong diagnoses. And this is a survival table analysis that we did from the onset of each of those common features, and you can see at the bottom right is that with dementia, there is a approximately mean age of survival of 7.5 years, and for myopathy and Paget, the mean age of survival after diagnosis is around 17 or 20 years. But of course, there is a spectrum. So as I mentioned, genotype-phenotype is very difficult because of the intrafamilial and interfamilial variations. However, we did notice one mutation that was unique, that stood out, and this was the R159H, R159 variant, C initially, in which Paget is much decreased. It's associated with later onset and a higher incidence of frontotemporal dementia, perhaps related to the later onset because there's a reduced chance of myopathy, which is what is the main cause of fatality in this condition. We looked at modifiers, and the one modifier that stood out was having 1 or 2 copies of ApoE4. It was strongly associated with dementia in this condition. Because of the multifaceted aspect of this disease, multidisciplinary care is needed. You need a village of different specialists to take care of the various needs. And up to now, there hasn't really been a standard set of recommendations for management of these patients, but with the help of Cure VCP Disease and Manisha Korb and an army of 50 plus experts in all these different areas, that a consortium was formed and recommendations were made for standard of care. And this manuscript is currently in review, and I'm expecting that it'll be very helpful once it's published. I will now move on to some of our preclinical studies that we did in the mouse model and using myoblasts. So Giles, my previous postdoc when I was at Boston Children's, and I designed this knock-in mouse model, which has this R155H variant, and it has these Cre-lock sites. It had a neocassette initially. And we have published the mouse initially with the neocassette in there still, and then when we remove the neocassette, the mice have weakness later on. There is some muscle phenotype in that there is increased centrally located nuclei, and there's increased TDP-43. And we have previously published that there is spinal cord degeneration. However, I'm sad to say that this heterozygote mouse has lost its phenotype largely. There is still the TDP pathology, but we have now turned our attention to the mouse that Dr. Mendel mentioned, the A232 mouse that Paul Taylor has generated, and the homozygous mouse, which carries two of the R155H variants, which is a potent model of this disease that you see over here. So these mice, you can distinguish them readily because of this loss of skin on their back. They're smaller, they're less active, and they only survive 3 weeks. That's it. And this is looking at the muscle pathology in their quadriceps and the heart. They have muscle degeneration, central nuclei, a lot of inclusions. And then when you look at the electron microscopy, you see very abnormal mitochondria, very misshapen, large mitochondria, and loss of architecture in the tissue. So we have also studied primary myoblasts. We've made these myoblasts into iPSCs. We've derived myoblasts from these iPSCs, and they have been an extremely useful model. This was our first paper where we obtained primary myoblasts from the Eurobiobank, and it had a phenotype in that there was increase of the autophagy markers, LAMP1 and LC3 and ubiquitin, and there were these vacuoles also in those original myoblasts that we studied. Because there's a limited supply of those myoblasts, and you can't really study them beyond a certain passage, we derive myoblasts from the iPSCs, and that actually has been a pretty good model. What you see here on the right, B panel, is the patient myoblasts versus control myoblasts, and there is increase in LC3, there's TDP-43 in the cytoplasm versus the nucleus, and P62 is also elevated. And what you see in the Western blot is that there is more cytoplasmic TDP-43, and there's no cytoplasmic TDP in the control myoblasts. So very quickly, some translational studies that we have done with our animal models and our cell models. This is important based on what Dr. Mendel has talked about, removing the mutation through CRISPR. Well, we used our existing mouse model to actually remove that mutation by crossing with a Cre-lox mouse. And what we found was that there was amelioration, quite in contrast to what we thought. We actually found that there was an amelioration. This is the structure of the mouse. So this was R155H mutation in exon 5, these two LOXP sites, and then we crossed with the Cre-lox, fed the mice tamoxifen, and studied both the grip strength as well as the muscle pathology. And you see in panel B at the top right is that was our mice then, and then the mouse that was fed the tamoxifen and crossed with Cre-lox, and then the wild type is the one with the normal muscle strength. And what you see here is there is amelioration with respect to the pathology that we saw. There's we found much less central nuclei, which was a useful marker for muscle pathology. We also found biochemical changes, but in the interest of time, I'm not going to share that with you. a big breakthrough came when we tried to make more of these homozygotes to study them, and EULA actually fed the mouse the prenatal, the pregnant dams a high-fat diet, and quite serendipitously we discovered that this rescued the early demise in these mice, and you can see that many of them live for long periods. They still don't have as normal a life as a non-mutant mouse, but when they do survive, they can live, for 2 years. And when you look at the child, there was an increase in many of the lipids, unsaturated, saturated, some of the amino acids. And what you see here on this panel is that the top panel, D, is just looking at the normal diet up to 3 weeks. Of course, they don't survive beyond. And then the other panels represent both wild type and these homozygotes fed a lipid-enriched diet from the prenatal period continuing on. So you can see that by 4 months, there's almost a normal pattern. There's still some variation in fiber size, but by 9 months, they are showing central nuclei, some breakdown, some more inflammatory cells. And you can test them, which you see in panel B, which is quite amazing since they typically die by 3 weeks. And we looked at the ceramide in these primary myoblasts from patients as well as these mice, and we found that the ceramide was elevated in these myoblasts. So we collaborated with Dr. Piomelli to see if we could modify this pathway for ceramide biosynthesis. So we studied myriocin, L-cycloserine on 14484, 94, which he designed as a way to reduce the ceramide production. And then as a positive control, we used the ON-082, which inhibits acid ceramidase, which actually will increase the amount of ceramide. And we found that using these drugs, we actually were able, compared to the white bar over there, we were able to reduce the amount of ceramide in both the mouse as well as the human myoblasts. And we see the changes here in the B panel, the treated cells, the myoblasts showed less TDP, less autophagy markers, and less ubiquitin compared to our positive control in panel C. And those are the quantification images at the bottom. And these are some Western blots which go along with what we saw by immunohistochemistry, the changes in the TDP, LC3, etc., for confirmation. And there is prior rationale for why high-fat diet may work. There are other publications where they've shown that it has been useful in ALS, in the ALS mice, and also in another mouse model in which there is microcephaly and abnormal lipid metabolism. So in summary, I have shown you a lot of data, but very brief in the interest of time. We are exploring new approaches for improving pathology, reducing this gain of function that is known to be caused by the VCP variants. We're looking at ceramide modifiers. We would love to do a human trial, and I'm working with a dietitian at UC Irvine on perhaps doing that as a study. We're exploring newer VCP inhibitors, working with Ionis and trying to knock down the VCP allele in the Taylor mouse, which is a humanized mouse model. Just to let you know that the R155H variant mutant mouse actually is not currently available. And we're very interested in gene therapy strategies. And I'm happy to report that yesterday we received a NOGA for an R1 to actually study gene therapy in VCP disease. So we're really excited. These are the platform and poster presentations at this meeting from my group. And I would ask you to check out the posters and attend the PowerPoint presentations that the various trainees have prepared for this meeting. So we're really excited. And thank you so much again for the kind invitation. We have lots to A lot of people to thank for my clinical projects, lab projects, numerous collaborators, and of course the funding agencies without which nothing is possible. Thank you.
Thank you, Virginia. Jordi, I think you're up.
So first, I would like to thank you very much for the organizers to invite me. Thank you, QVCP. It's also my pleasure to be in the first conference organized by the Patient Association. And I'm going to talk about a slightly different topic than the one that Virginia has talked just before me. I'm going to talk about the utility of muscle MRI for the diagnosis of BCP muscle disease. So these are my discussers. None of them are related to the content of this talk. And just a brief introduction, you have already heard that this is a rare genetic disorder with a dominant inheritance that is produced by mutations in the BCP gene, and is actually a multisystemic disease that is mainly characterized, what was first described as a triad of three different syndromes, including myopathy, Paget disease of the bone, and also dementia. But we know already that patients can also develop other symptoms, including dysautonomia, motor neuron disease, or peripheral neuropathy. So all the results that I'm going to present are based in this international BCP cohort study. So this is a study that we started. It's a collaborative study that we started more or less 1 year ago. And it's an international effort to collect clinical, genetic, MRI, and muscle morphology data of the largest possible cohort of patients. So the aim of this is an open study. Everybody, all clinicians in the world that are following patients are welcome to collaborate with this. And the main idea is just to gather data and analyze with some clear aims. The aims are the one that you see here, so to gain knowledge in the clinical features of patients and also to obtain information about the progression of the disease, to identify phenotype-genotype correlations if possible, identify new mutations, to know about muscle MRI features, characterize the changes in the muscle biopsies of patients, and all these to prepare the landscape for a full international collaborative natural history study, if possible, and also to speed up clinical trial readiness in BCP disease. So far, we have included in this study data from 223 patients that are from 175 different families. You can see here that 70% of the patients included in the study are male, and that just to show you some data, demographic data. So the mean age of symptom onset in our cohort was 45.6 years, ranging from 18 to 71, and the mean disease progression, this is since the first symptoms to the last assessment, was 11 years, with a range to 1 to 45 years. So Marianela Schiava is an excellent neurologist working with us here in Newcastle, and she is going to present two talks about the clinical data that we have collected so far. I strongly recommend you to her talk. And just to show you some of the data. So how does this disease start? We have identified that in most of the cases, patients start with weakness, and this weakness tend to be proximal, involving the lower limbs and symmetric, but can also present in different ways, as you can see here. So patients can also present with distal lower limbs involvement, but also with proximal upper limbs involvement, or also with proximal upper and lower limbs. So although all patients present weakness, the pattern at the beginning can be very different and variable from one patient to the other. So it can be sometimes difficult to identify them in clinics if they came just when they are starting the disease. So as you can see, if we combine these numbers, more or less 50% of the patients have a linked representation, but 50% of the patients can be identified as distal myopathies. Another important point is that although I mentioned that there is a typical triad of symptoms, in our cohort only 4% of the patients present with Paget, and just 0.4% of the patients present with frontotemporal dementia. So it seems that almost in our cohort, weakness is the main presenting symptom. How the disease progress. So what we have seen is that almost all patients will develop weakness during disease progression, while the development of cognitive problems, or Paget, is less common. As you can see in our cohort, 27% of the patients develop cognitive problems and 25% develop Paget. So, and the triad of symptoms was only seen in 4% of the patients. So, and what about weakness? Because if we know that this is the more common symptom, how weakness progress? So what we know is that almost all patients are going to develop proximal lower limb weakness sooner or later, and most of them will also develop proximal upper limb weakness. So even if they have a start as a distal myopathy, they will develop proximal involvement of the lower and upper limbs. And not only that, patients can also develop very frequently in weakness of the distal muscles, both in the lower limbs and also in the upper limbs. So what we have is that most of the patients are going to have generalized muscle weakness. So if we are seeing one of these patients in our clinics at the latest stages of the disease that isn't diagnosed, it can also be helpful to define a pattern of involvement that can help in guiding the diagnosis, because these patients can have proximal and distal involvement of both the upper and lower limbs. Half of the patients will have axial weakness, and half of the patients will have, as you can see here, scapular weakness. And what we have seen is that this is a quickly progressive disease, I would say, because the time from onset of symptoms to the wheelchair is 10 more plus less 7 years as a mean. And okay, so having all this in mind, what is the diagnosis delay? So there is a clear diagnosis delay in patients with VCP. As you can see here in our cohort, the mean is 8.3 years, with a range that goes from 1 to 28 years. How can the diagnosis be sped up then? Well, we can try to use clinical data. So we will have a patient that has a quickly progressive myopathy affecting proximal and distal muscles with camptocornea and axial weakness and scapular winging. That can be a good clue. If we have a patient that has also Paget disease of the bone and cognitive problems, for sure that's an excellent clue for the diagnosis. But if we see a patient with a muscle disease that has central nervous system involvement, including dysautonomia, peripheral neuropathy, Parkinson's, this is another important clue. So the dominant inheritance can also help us. They are more recessive than dominant diseases in neuromuscular. So if we have a clear dominant family, this is also a good clue for the diagnosis. Muscle biopsy data, Virginia already showed that patients can have backwards and inclusions in the muscle fibers, another good clue, and muscle MRI. And during the next 10 minutes, I will try to convince you that muscle MRI can be useful for the diagnosis of these patients. So why muscle MRI can be useful? Well, muscle MRI has been used for many, many years to study the disease progression and also to study the patterns of muscle that are affected in patients. Why? Well, we need to look a little bit before muscle MRI. We need to go first to the tissue to understand what MRI can bring to the clinicians. When we have a disease, what we know is that we start with a healthy muscle that lacks a protein, and this protein, the fact that the muscle is not expressing this protein will induce some changes in the muscle fibers that will induce necrosis, inflammation, and loss of muscle fibers. And these muscle fibers that are lost are progressively being replaced by fibrotic and fat tissue that has no contractile properties and is contributing to permanent weakness and disability. So this is what we can see with a microscope. But with the MRI, we can try to identify these two different processes. So we can try to identify necrosis and inflammation with an MRI technique that is called STIR. And this will allow us to see an impaired intensity in the muscle that corresponds to the presence of water, what we call edema, that is the typical sign that we see when there is inflammation. The STIR is associated to acute damage. So muscle fibers that are being lost and muscle fibers that are being replaced by fibrotic tissue, but that the fibers are actively damaged. If we want to study the presence of fat tissue, we can use T1. And with T1, we will see that fat is progressively replacing the muscles. You can see here in this picture that you have the fat, subcutaneous fat that is normal, but you can see that the muscles that normally gray, dark, or brown, they are replaced by white tissue that is fat. And this is a measure of chronic damage. So muscle fibers are gone and substituted by this fat tissue. So why are we using MRI? Because we know that clinical phenotypes can be very similar across different neuromuscular diseases, and sometimes from a clinical point of view can be very difficult to distinguish one from the other. And we know that the muscle fatty replacement is not random. It depends of where the mutation is. For example, there are genes where the muscles that are more commonly affected are the posterior muscles of the thighs, while there are other genes where the muscles that are more commonly affected are the anterior muscles of the thighs. So to identify patterns that have been described and are associated to specific mutations in genes or a group of genes can be useful for the diagnosis. There are things that we can look at. For example, let me show you these 3 examples of patients with different diseases. We can have patients where the fatty replacement is general, and as you can see here, the whole muscle is substituted. This is what we see in muscular dystrophies, for example. This is the typical image of a muscular dystrophy. In other patients, what we have is a kind of mixture between remaining muscle and fat. The muscle becomes just pale. It's like it's losing the color before becoming white. And this is what we call the marble pattern that is typical of congenital myopathies. And then there is another pattern that can be seen where the muscle is substituted, but there are still islands of normal muscle within the fat tissue. As you can see here, these spots of normal muscle within the fat tissue. And this is what we call the patchy infiltration. This is commonly seen in neurogenic diseases. Then there are other things that we can look at. For example, if we have an MRI, we can look at the presence of asymmetries, and there are some very asymmetric diseases. And sure that clinicians can think about, for example, FSHD, where you can have these asymmetries, DMD carriers, you know they are very asymmetric, IBM, dysferlin, etc. And we know that there are some common patterns, for example, for muscular dystrophies. For example, in muscular dystrophies, patients with mutations in dystrophin, dysferlin, or NO5, as I said before, they have predominant anterior involvement. While patients with mutations in calpain or fukutin, they have predominant posterior involvement of the thighs. So there are some groups of muscle that are affected in groups of diseases as well. In the last 20 years, there have been many publications describing the patterns that are associated to specific diseases. And at this moment, we have several algorithms useful for the useful to guide the diagnostic, just analyzing the MRIs, and all this is already published. So in general, muscle MRI is a tool that can be used by clinicians. But what do we know about MRI in BCP patients? Not so much. So in this international BCP cohort study, we have collected 92 MRIs of patients that are included in the whole study. So we have the clinical genetic data of these patients, but we have also 90 day MRI. And we have started analyzing them. So today I'm going to present unpublished data of the 21st patients that we have analyzed. These are 15 males and 6 females. Most of the studies that we have T1 and STIR and are mainly focused in pelvis and lower limb muscles. You have here the demographic data of the patients that we have analyzed in MRI. So the first thing that is very clear in BCP is that the patients have a pattern of fat replacement that is very similar to the neurogenic one, the patchy infiltration, what is also known as fat pockets. You can see here that there is focal intramuscular areas of fat replacement. And this is something that can be clearly identified in the basti muscles, but it can be seen in any muscle that is affected, for example, the glutei. As I said before, this is not a specific of BCP and can be sometimes seen in other neurogenic diseases, like, for example, a spinal muscle atrophy. You have here 3 examples of that, or in general, patients with Charcot-Marie-Tooth or other neurogenic diseases. But this is not common in limb-girdle muscular dystrophies or other myopathies. So if you have one patient in clinics and you say, okay, this could be a limb-girdle, muscle biopsy fits very well, or a myofibrillar myopathy, but I don't have a clear idea what the diagnosis could be, and you have an MRI that is clearly patchy, that BCP could be an option. But if you have a patient with more distal involvement, with clear atrophy, remember, for example, that Charcot-Marie-Tooth can have a similar pattern. And always remember spinal muscle atrophy, right? I mean, so this is not a specific of PCP, but can be seen. What about the muscles that are affected, the pattern? Well, when we analyze muscles, what we do is that we give a score to the muscle depending on the amount of fat the muscle has. 0 is that there is no fat at all. 4 is that the muscle is completely substituted by fat. And then we have 1, 2, and 3. 1 is less than 30%, 2 more than 30%, and 3 more than 60%. When we analyze this, what we try to do is to do just a clustering study using heat maps and try to avoid any human interpretation. So we just use a computer that will organize our muscles from more affected to less affected and patients from more affected to less affected, producing these heat maps. So here, what we have is based in the Mercury score, what we are analyzing is the muscles that are more affected and less affected, so from the left to the right, and the patients that are less affected and more affected from the bottom to the top of the figure. And what we can see, for example, is that there are patients that can have minimum fat replacement when they are at the very beginning of the disease, while there are patients that they have a severe fat replacement when they are in later stages of the disease. But moreover, we can also learn about what are the muscles, because we have these dendrograms. And in the dendrograms, we can identify in blue, for example, a group of muscles that are commonly affected in all our patients, but also a group of muscles that are less affected in orange in our patients. Let's go through this information. In the case of the trunk and the pelvic muscles, what we have learned with these first 21 patients is that there is a group of muscles that are commonly affected in this area, and these muscles are the paraspinal muscles, as you can see here, that tend to be replaced in almost all patients, as you can see, and then the gluteus minor, that is this small muscle here. Then, in patients that are a little bit in more advanced stages, we can also have involvement of other muscles, mainly the gluteal. And as you can see here, not only the gluteus minor, but also the gluteus medius and gluteus maximus, they can be both affected with the typical fat pockets. And we have also learned that muscles of the pelvic floor are not affected in our patients. If we move now to the side, we have again identified a group of muscles that is commonly affected, and this includes the basti muscle, so the quadriceps, that you can see clearly the fat pockets here, but also the adductor magnus, which is this muscle here, and then you can also see involvement of the posterior muscles of the thighs, the biceps, as you can see here, the semitendinosus and semimembranosus. But there are 3 muscles that are very rarely affected, and these 3 muscles are the rectus femoris, the gracilis, and the adductor longus, which is this one here. So again, a group of muscles that are commonly affected and others that are less affected. And if we go now to the leg, sorry, there is a mistake here. This is the leg, the lower leg. We can again identify 2 muscles that are commonly affected in almost all patients. These are the gastrocnemius medialis and the soleus, as you can see here. And then a group of muscles that is commonly affected, including the tibialis anterior, the gastrocnemius lateralis, and also the peroneus longus, that is the group of the peroneal muscles. And again, a group of muscles that is very rarely affected, and this is the tibialis posterior, which is this muscle here, and also you can see an advanced case where the tibialis posterior is not affected, and also the popliteus, which is a very small muscle close to the knee. So, the summary so far. Fat pockets are one of the main features of the disease. If you have fat pockets in MRI, this could be VCP. Muscles commonly affected, paraspinal, gluteus medius, remember, quadriceps, adductor magnus, and the semimembranosus. And in the legs, the gastromedialis and soleus, and then the anterior muscles of the legs. Muscles that are rarely affected are the pelvic floor, something that we don't see, gracilis, rectus femoris, and adductor longus, and the tibialis posterior. So if you have a patient that has fat pockets, and this combination, remember that this could be VCP. What is the differential diagnosis? Well, we have said before that fat pockets, patch infiltration can be seen in neurogenic diseases like SMA. But if we take a look to the pattern in SMA, that's pretty different, because in the thighs, SMA patients have the adductor magnum that is always, almost always, a spurt. That's different from VCP. So we can differentiate between one and the other, just taking a look to this big muscle on the thigh. If we take a look to the distal muscle, so to the leg muscle, remember that the spinal muscle atrophy patients can be with a predominantly proximal involvement, and in these cases, distal muscles tends to be normal. Or they can also have predominant distal involvement. It's what is known as distal hereditary motor neuropathy. And here, what you can see is that the distal muscles can be completely replaced. So sometimes the differential diagnosis can be trickier here. Is there inflammation in the muscle? How is stir? Well, in the patients that we have identified, half of them has increase in a stir signal in muscles that are not replaced by fat, like, for example, the quadriceps in this patient. Here you can see here in the soleus, or, for example, in other muscles of the leg. So suggesting that there is an active infiltration of inflammatory cells of the muscle in these patients. What is missing? Well, we need data from a longer cohort. We are now studying that, but that could include upper limbs and cranial muscles. And this is something that, unfortunately, we are not going to have because most of the studies so far are done just in lower limbs. It would be great to have a good correlation with muscle function test. So including muscle MRI in natural history studies could be really useful to know if muscle MRI is also a good biomarker of disease progression. Also, longitudinal data using quantitative MRI to understand if we can catch or we can capture how the disease progresses using MRI. And I think that there are new sequences that can be used, like, for example, T2, that is useful to identify disease activity or inflammation. Diffusion tensor imaging that allow us to do tractography of the muscle fibers and identify if there is a change in the muscle fiber size. And of course, with the fact that there are backwalls of different protein aggregates, PET MRI is something that could be also explored in the future. And that's my last slide. I would like to thank especially to Marianela Schiava, who is this excellent PhD student that, apart of focusing her PhD, is also collaborating with us, with me in the analysis of the data. I would like to thank also Marta Caballero from Barcelona, who started the project with me here in Newcastle. For sure to Chris Well for her huge help understanding many things on BCP, and also for Tanya Stokopit, who was one of the first that had the idea to collect data of these patients. And for sure to the whole BCP International Study Group that includes 51 centers in 24 countries in 4 different continents. Thank you very much to you for your attention.
Thank you, Jordi, and we will move on to Dr. Pfeffer next.
Okay, so thank you very much for the chance to present before all of you today. I'm going to give a presentation briefly going over genotype-phenotype correlation in VCP-related disease, and then a little bit of additional discussion about genetic modifiers and the importance of this relatively newer concept. So first, I'd like to acknowledge that I have no competing interests to report. I'm giving this presentation from the University of Calgary, which is on the traditional territories of the people in the Treaty 7 region and home of the Métis Nation of Alberta in Region 3. Because this is only supposed to be a 15-minute presentation, I'm only going to cover 2 topics that might feel uncomfortable, but we'll try and get through these. And I'll start with this slide, which is the largest cohort of patients that's been published, and tells us a little bit about the phenotypic diversity that is present in VCP-related disease as corresponding to genotype. Now, genotype-phenotype correlation is easy in situations where a mutation reliably produces a particular phenotype. But as you can see, particularly for these where we have more data, there's a big spread of the different phenotypes that are present. Now, that leads us to this figure, which Dr. Kimonis also showed, demonstrating that inclusion body myopathy appears to be the most common phenotype that we're going to see in most of the cases. But I do want to come back to this and just emphasize that these data may not be 100% complete or representative of the full picture of VCP-related disease. The vast majority of the participants in these studies are from mutations at a single amino acid position. When further subgroup analysis was done, for example, the authors showed that with the 159C mutation, that the age of onset at position 155 is about 15 to 20 years earlier than it is at position 159. It leads us to wonder whether there could be, for example, an ascertainment or diagnostic issue that might explain the fact that we don't see later onset phenotypes as much. And so I wanted to talk briefly about diagnostic delay, lessons we can learn from the ALS literature that may tell us about why we have to work very hard in BCP-related disease to really understand the phenotype. So in this paper, looking at time to diagnosis in patients with ALS, they showed, for example, that a later age at disease onset is associated with a much lengthier diagnostic delay. They also showed that in patients with neurologic comorbidities, so greater complexity of cases, that the diagnostic delay was extended here. So these are both issues that we encounter with VCP-related disease. It's a later onset disorder, and these are complex presentations. So the ascertainment of cases may be very difficult. Particularly if the phenotypes are milder and presenting later. This data from ALS-related work also shows us that in patients with a more severe disease course, that there tended to be a shorter diagnostic delay than patients who had more of a chronic disease course. So this again shows us some of the challenges that we encounter with VCP-related disease as well, where the progression rate tends to be slower and more gradual, as in higher up in this graph. The other thing that is shown that certain luck factors, such as which type of specialist you may present to first, also influences the speed at which you might get diagnosed, in this study shown by Kano and colleagues. Nonetheless, there do appear to be some phenotypes in which there is a somewhat clear genotype-phenotype correlation. We have a few mutations that are described only with axonal neuropathy or Charcot-Marie-Tooth type disease, and 2 mutations associated with spastic paraplegia. But again, further study is required because these are very small numbers of cases with late onset. It's possible, of course, that there could be an ascertainment issue. Of course, in the genomic sequencing era, you can pick up more of these cases than you used to, but you can only diagnose VCP if you weren't looking for it, if it is broadly included on genetic testing panels. And this is not always the case. So the key points here is that genotype-phenotype correlation is very challenging in VCP. The data are mainly from a single position in the gene in the currently published data, although I can see already from Dr. Manera's presentation and his preliminary data that it looks like there will be some change with that, which is great. And there are challenges with diagnostic delay and ascertainment, which can be dealt with by having VCP included in a broad variety of phenotypes for testing. Some mutations may still have clear correlations, so there's still value in checking for possible clear phenotypic correlations when you get genetic testing results. And so now I'll speak briefly about genetic modifiers in BCP. You can't talk about genetic modifiers without talking about coincident genetic diagnoses. It's a relatively new concept that just because you have one monogenic disease doesn't mean that you can't have others. It's now fairly well known that about 5% of people with monogenic diseases can have a second or third or fourth monogenic diagnosis, which tends to create a situation in which you get so-called composite effects or additive effects of these 2 different monogenic disorders. This is conceptually a little bit different from genetic modifiers. And this schematic cartoon illustrates the issue. You have, for example, a parent with a monogenic disorder and another healthy parent who has a modifier gene. That modifier mutation does not cause disease by itself, but in the children, when it's combined with a mutation from the monogenic disorder, it can result either in increased severity or decreased severity of the condition. These are very difficult to identify, and unfortunately very few examples of true genetic modifiers in the literature. And I just wanted to add to this, not that I'm second-guessing anybody, but there's also potentially the situation where a modifier could result in a qualitative phenotypic change where it may not resemble the monogenic disorder as clearly anymore. And we may have a case of that coming up later in this presentation. As I mentioned, genetic modifier research for rare diseases is at a very early stage. From this excellent review that was published just last year, this appears to be the full list of genetic modifiers that they were able to find in their literature review. And I've highlighted here spinal muscular atrophy because most of us as neuromuscular specialists are aware of the modifier effects of SMN2 copy number in SMA phenotype. But otherwise, we do not have too much to look at when it comes to neuromuscular disease. Many of you may be aware of modifiers for dystrophinopathy, which are not present in this table. But again, the list is relatively short. There are some resources that recognize the importance of this problem and are starting to collect and curate such data. So I've brought to attention Phenomodifier just because this is a newer resource that has become available and it appears to be active. There are prior resources that have come up in the last 7 or 8 years, but many of these appear to be unfortunately inactive or out of date at this time. And by the way, I searched Phenomodifier about a few hours ago for VCP, and nothing is listed. Now, in terms of the methods that you can use to identify modifiers, they give a schematic cartoon in this review to speculate about what kinds of methods you could use, whether you use genome-wide association or exome/genome sequencing, or whether you're using other techniques such as family linkage. And they're saying that ideally, if you want to identify a genetic modifier that could be common in the population, you need huge numbers of participants in the tens of thousands. That's not something that's going to be feasible in the case of VCP-related conditions. We're looking more in the range of small to moderate numbers of participants. Even so, the types of variants that we would have statistical power to detect would be extremely rare, which means that more common modifier variants may be a huge challenge to identify. The types of cases we should probably be looking at in order to try and identify modifiers could include cases with extreme variability. There's one report published where there was a family of 3 patients with the same mutation who were first-degree relatives, but one had FTD, one had ALS, one had myopathy. And the other is to focus on cases with restricted or extreme phenotypes, such as, for example, distal myopathy or movement disorders. Now, Dr. Kimonis did mention already the association of ApoE4 allele as a modifier to VCP phenotype, but it's worth mentioning again that this is a true modifier as far as I'm concerned, and not simply an additive effect of the ApoE4 allele. ApoE4 is associated with Alzheimer, dementia. FTD is quite a different presentation from Alzheimer dementia, so it does appear there does appear to be a true interaction here. Of course, this is still with a small number of participants, and it would be nice to see this replicated in future study. And very, very recently, there was a case report of a patient with a VCP variant with an intermediate SCA2 expansion who presented in early adulthood with ataxia and Parkinsonism. This is fairly remarkable, I would say. Not truly a perhaps not truly a modifier effect. Difficult to say with only one case. Typically, intermediate expansions are considered to be more associated with ALS, but the full expansion of SCA2 does cause a neurodegenerative condition featuring ataxia and Parkinsonism. And finally, I wanted to end off my presentation by giving a case presentation that demonstrates another modifier variant that we think is relevant to VCP-related disease. This is a case from my practice, a 52-year-old woman with long-standing gait issues. The initial presentation was asymmetric, and it only had recently become problematic. On her examination, she had bilateral foot drop with weakness of muscles around the ankles and toes, predominantly the dorsiflexors. And on later examinations, she developed finger extensor weakness, resembling a Wiellander myopathy phenotype. Interestingly, her neurophysiology showed myotonia and denervation changes, and her CK showed a mild elevation. And this is what the family structure looks like. She has 2 healthy adult children. Her father had apparently had mobility issues, but she wasn't aware of further information. We proceeded with a muscle biopsy on this patient, and you can see on the H&E that there's rather substantial fiber size variability, which is a non-specific finding for myopathy. There's here a rimmed vacuole, which is one of the characteristic findings in VCP among other myopathies, and granular cytoplasmic staining for TDP43 shown in this image. So we had performed exome sequencing in this patient, and interestingly, we identified what was a known pathogenic mutation in VCP. That one was not so controversial, but as part of our filtering, we looked very carefully at TL1 because TL1 is associated with Wiellander myopathy, and that was the phenotype the patient was presenting with. And we found this variant that is reported in ClinVar as being benign and is present in the population with an allele frequency of around 1 or 2%, which is normally way too frequent to be associated with disease. But this variant is not simply benign. It's a little more complicated than that. We were aware of a couple of publications which showed that the coexistence of this TL1 variant with sequestosome 1 mutations caused a distal myopathy phenotype that looks just like this. And this is of interest, of course, because sequestosome 1 is another gene that causes multisystem proteinopathy. And their patients showed this MRI picture where the upper legs looked relatively unaffected, but in the lower legs, there's predominantly gastrosoleus involvement. We had done the same in our patient and showed a similar picture where the upper leg was not very much involved, but in the lower leg there was involvement of the medial gastroc and tibialis anterior. And for comparison, this is what the typical upper leg findings for VCP would look like, though of course this is no longer necessary after Dr. Manera's excellent presentation. So we followed up with, on this result, of course. This particular mutation is associated with high phenotypic variability and variability in penetrance. And we went back to the patient and said, are you really sure, tell us more about the father. And records review actually showed that the father and the uncle both had Paget disease of bone, but that it was unknown to our patients. We contacted other authors of papers reporting other distal myopathy VCP cases in the literature. And one of us got back to us and looked for this same TL1 variant, and their case has it as well. So I think this may be a true and novel modifier for VCP mutations. And of course, that's not enough by itself, you know, these two cases that I'm talking about. So if you want to learn more, please see my student Carly Pontifex's presentation, where she's done some very nice preclinical work looking at in vitro studies in cell lines from these patients. So key points here, VCP has a few described genetic modifiers that are all very preliminary and all require further study. Certainly, this should be an important piece of future collaborative study combining genomics and deep phenotype